Hello, everybody. Welcome on this wonderful late afternoon to our next webinar. Good to see all of you. We will give everybody a few minutes to join our meeting room. So we will not directly start, but maybe a few minutes after 5. But it's so good to see already so many of you here with us today. Hello, everybody. Also for the others that just came in and joined us. Good to see you. Many well-known names. That's really, really great. We will just wait a few more minutes so that everybody has the chance to join and be there from the beginning on. So you can take also 1 or 2 minutes for yourself, maybe get a coffee or something else for your hydration. And then we will start. But it's good to see so many of you. I'm now thinking we should install a nice background elevator music so it's not so freaking silent in here. Oh, but it's great to see you. Let's see, maybe 1 or 2 minutes more, and that will start. Okay. Let's see, Mariangela, are there still people coming in?
Not anymore. No.
Not anymore? Okay.
No.
Then I think we can start very slowly. So, once again, hello everybody. It's very good to see all of you on this beautiful afternoon for our webinar about the topic of mental health and psychosocial recommendations on mental health and psychosocial support. Um, I'm very happy that I can moderate this wonderful webinar today for you. We will have in the beginning a presentation, and then after that, hopefully lively and interactive panel with some really, really great panelists that we have invited for you. But we also are hoping that you will be as interested and interactive as we are. So there will be also the invitation for you to ask questions and engage in this discussion. But for now, let's start with the presentation and also um, with some housekeeping rules. So, as already said, we are here today for the topic from recommendations to real life mental health in CAYA Cancer Survivorship. This is a webinar happening during the amazing Yarn project, which is co-funded by the European Union and happening during the quality of life webinar series within this project. As already said, and as always, some housekeeping rules for you. So as you might have seen, this webinar is recorded at the moment and will also then later on be publicly available on YouTube. So in case you don't want to have your name or your face in that recording, it's totally fine if you turn off or keep off turned your camera and also change your name. That is totally fine and very up to you. And we'd like also to ask you to keep yourself muted throughout the event, unless, of course, you would like to say or ask something. Then please raise your virtual hand, and we will invite you then to speak. In case you have some questions, please just put them into the chat. So for the presentation, and we will address them then in the end. When it comes then to the panel, it is also fine to just raise your hand and speak up. But this putting the questions in the chat would be for the time of the presentation. So that's it. We only have 3 of them today, keeping it simple. So yes, so we are going to start with a few Slidos because, of course, also we want to know who is with us in the room. So please turn out your phones, scan the QR code, and we have prepared for now 2 questions for you. You can, of course, also answer this Slido on your computer when you go on slido.com and enter this code there. Then you can also reach the Slido. So that's really great. We can see that we are having a lot of survivors here, patient advocates, really great, but also healthcare professionals and carer or other relatives of a patient or a survivor. It's filling up. That's good to see. Let's wait a few minutes more. The moment healthcare professionals are winning, but also patient advocates and survivors are there. That's great. More coming in. Let's just give it a few more seconds. But we're quite evenly distributed. That's very great. Thank you so much. Maybe waiting for, perfect. I like even numbers, so I wanted to wait for 20 at least answers, which is great. So thank you very much. Going up to the next Slido. And we would be very interested to see what your expectations for the webinar are today. Hoping, of course, that we can meet them, network. That's good. We hope that we can network a lot in the end, especially during the panel. Let's see what else is coming up. Learning. Oh, hope that we can achieve that. Important for healthcare professionals. Very good to read. Yes, defining goals. Nice. Learning something new, learn more. Okay, so I can see a lot of learning. That's good. I hope we can achieve that. I'm sure we can. Telling you some new things. That's good. Get inspired. I like that. Very good. Also important aside the learning. Setting the standard. Oh, that's a nice one. Very good. What else do we have? Get inspired. Ooh, wow, that got big now. That's great. Are there more coming in? No, I think there is nobody typing anymore. Okay, that's great. We'll see if we can meet these expectations in the end. Thank you so much. Then we will go on and maybe show a very quick overview about the content of the webinar. So as already said, we are starting with a presentation where we would like to yeah, get everybody on the same side. Probably most of you already know some things that we're going to show you in the presentation, but so that just everybody is on the same side, we're going to define the problem, starting with defining the problem and giving an overview on mental health needs and care gaps, going then on with the development of recommendations that we did in EU-CAYAS Net, which was the previous project before Yarn, showing you also the methodology that we had for defining these recommendations, and then obviously also giving an overview of all the recommendations, giving also maybe some inputs and inspiration for possible implementation on that. And that will be then followed by the panel discussion, kind of mixed a bit with the Q&A. So that's it for today. And with that, I would like to introduce you, my co-presenter. Oh, by the way, I just realized I never introduced myself. So hi, my name is Hannah. I'm working for CCI Europe as a project manager and patient expert, meaning I'm a survivor myself, but also a psychologist. And yeah, I'm very happy to be here today with you for moderating and also being part of the presentation that I just introduced. And my co-presenter for this will be Anna Zettel. She's also a patient expert and researcher and project coordinator at the Medical University of Vienna within the YARN project. She has a master's degree in anthropology and is currently studying psychology. And she's also very active as a patient expert on a national and international level. So let's start with defining the problem. For all those who don't know, and just to not cause any confusions, before Yarn, there was also another project in which we created actually these recommendations where we will be focusing on during this webinar. This was actually the first project of this kind, meaning this was a project that was really led by patient advocates and patient organizations in the driving seat to really create a platform and a community over whole Europe, but also defining and creating a kind of a knowledge base within this huge and very scary place called the internet. And as you can see here, this was also co-funded by the European Union. We had 9 beneficiaries from the patient and parents organization site, but also together with healthcare professionals, institutions, and organizations, we created really, really great things. Which one of these is the recommendations we're going to talk about, but also a survey that was happening within this project. And this is what we're going to focus on more a bit today. So maybe to start, this is maybe now not something that was happening during EU-CAYAS, but that happened before, which was a publication done by the IGHG group, so the international group, international guideline harmonization group, sorry, on recommendations for the surveillance of mental health problems in childhood, adolescent, and young adult cancer survivors. And this is kind of a report from this group on the different things that might be coming up in this time. So we know that survivors of childhood and adolescent cancer have a higher risk of clinically relevant mental health problems compared to control groups or instrument norms. For example, as you can see here, we know that depression and other emotional disorders might be definitely higher than in other groups. This differs between 2 and 40%, which is pretty high. We also know that an anxiety disorder is much more likely when it comes to people living with and beyond cancer. This differs between 1.2 and 27.6%. Also looking at the group of post-traumatic stress disorders, also here we can see that this is a likelihood up to 18%. Also looking at stress-related related mental disorders or post-traumatic stress symptoms. So all of this is much more higher in the group of people living with and beyond cancer. We also can see that behavioral problems are more likely, and in the end, also suicidal thoughts or even suicide is something that is higher than in the control groups. And all of this is showing actually that there is a big issue and that there is a big need when it comes to psychosocial support in this group, which was then in the end showed in this survey that we did within EU-CAYAS net, where 33 to 57% indicated really a need for support when it comes to psychosocial dimensions. And that is even an issue before it actually comes to a clinical relevant disorder, because we know that mental health is actually more than just the absence of mental disorders. And this is what we showed within this study. Going up to the next slide. So I talked now a lot about this online survey for EU-CAYAS net, but what happened within this study? So this was really to understand or better understand the current status and gaps when it comes to psychosocial support in survivorship. We did this, or we created this survey together with patient advocates and healthcare professionals. This was evidence, but also consensus based. Especially the consensus was to understand what are additional topics that we need to cover with this study, and also get really much more closer to the needs when it comes to psychosocial support. And we conducted this survey in from November 2023 to April 2024, and we were able to get 195 participants with a mean age of 30 from 24 different countries within Europe. The oncological treatment happened between the years 1967 to 2023. From those who answered to this study. And we also had a quite broad variety of diseases. We had hematological or blood cancer. We also had brain or other neurological cancer types, and also survivors from any other cancer type, which were 25%. 51.9 people received already long-term follow-up care in the past, but only 39.7 are also currently, so meaning at the time point of the study, receiving long-term follow-up care. So this is what the survey was based on. So what we could show through this survey, focusing now on information and knowledge when it comes to long-term psychosocial side effects. And one of the questions that we asked were if the person living with and beyond cancer was informed that the disease or the treatment would or could issue psychosocial late effects in the end. And to that, 62.8% said no, they were not informed about this previously. Only 27.9 could answer that with a clear yes. Um, then we also asked the question on how they feel about this, about the information that they received. And there was a very clear number of 86.7% that said they would have liked much more information about psychosocial late effects in the end, and only 10.9 people said that it's okay for them that they did not receive more information about that. So that's a very, very clear answer um, on the question if survivors or basically people living with and beyond cancer, if they want to be informed or not. Um, and then we also had the question on how they would describe their knowledge of treatment-related psychosocial late effects. And also here we got a pretty clear answer on that question because 52.3% said they did not have enough information about this, and 26.6 people percent, sorry, said that they also did not receive any information about that. So we can clearly see as a conclusion that there is really insufficient knowledge and education about long-term psychosocial effects, and also that survivors really want to know more and kind of want to be informed and warned about this issue beforehand. We can see that mental health is coming up in many dimensions. I already mentioned it before that psychosocial health is really a spectrum, and it's not only the absence of mental disorders. It's psychosocial burden is something that comes up on many different dimensions. We know that this is also affecting the social dimension. We are having this on the psychosocial dimension. This also happens due to physical long-term effects, and also due to factors that are independent of the disease. So we can see that many, many different dimensions are included into that. From previous papers, we already know that anxiety disorders are more common than in siblings or the general population, which is up to 27.6%. And these are now numbers that we brought from the survey that we then followed on that did within EU-CAYAS net. And here you can see that 57% of those who answered the survey said that when we look now, especially, for example, at the increased anxiety or anxiety disorder, that 57% reported that there is that they are really having a need for support within that area. So this is here, you can see it. When it comes then that these issues have been addressed beforehand, only 16% reported that this actually happened for them, followed by 24% that actually received support. But which is much more frightening actually in the end is that we also had the group of people that needed actually support and where these issues were also addressed, which is only a percentage of 5.7%, which is very, very low. And if we then also look at the group of people that needed support and actually received support, this is only a percentage of 8.2%. And I think we all can agree that this is in the end definitely not enough, and that this is a number that we need to increase all over Europe. So I have mentioned the different dimensions before, so that when it comes to psychosocial burden, that we have different dimensions, which is the social dimensions, which you can see up here in the left corner, that we have also obviously have the psychosocial dimension. In the right upper corner, you can see the physical change related burden, and down in light blue, you can see the burden when it comes to unrelated disease issues. But here in the middle dark blue bars, you can see these bold printed parts, which were reported together with the biggest issues for people living with and beyond cancer. This is especially meeting the issues when it comes to emotional distress during the adaptation, but also covering chronic emotional stress or sorrow, coming to fear of cancer recurrence, depressive mood, or even a depressive disorder, to acute stress reactions and increased anxiety or even anxiety disorders. So you can see this have been really a high number of people that are having big needs within especially these areas. But also, for example, up here, when it comes to social relations and friendships, financial issues, isolation, all of these are still areas with a huge need by this group. So, coming to a conclusion, we can see that there is a big need still when it comes to communication about psychosocial led effects, so that actually the need is much bigger than communication that actually happens. And then followed that also this is much bigger than the support that is actually received by people living with and beyond cancer. Um, and the need is not only there for actual clinical disorders when it comes to psychosocial health, because as already said, and I cannot say it often enough, this is a continuum, this is a spectrum, and mental health is so much more than not having a disorder. So there is many kind of gray areas in between that also need to be addressed and also need to be covered by support and communication. Also, we could see that 47.4% had already felt that their needs that they talked about had been really misunderstood. And also 18.1% had really the feeling that they had been misdiagnosed and would need much more care that is coming with also an understanding when it comes to oncological diseases. So, followed by all these numbers and by all these issues that have been raised, what did we have in mind when we were planning the joint recommendations for mental health and psychosocial care in CAYA Cancer Survivorship? We really wanted to base this on already existing guidelines and standards of care that are already out there, but still get in the input from the community. So also this, as already the survey had been, but also this has been building on consensus-based decision and on a consensus-based process involving healthcare professionals and patient advocates when it comes to the content, but also to the language. Because the goal was really to tailor these recommendations to the needs that are out there. On the one hand, of course, of the patients and survivors community, but also getting in the thoughts and the input from the healthcare professionals themselves. And this should really lay the foundation for awareness raising, helping lobbying within health policy, and in the end, hopefully, facilitate also the implementation of these recommendations from the community side. And with that, I will give the word now to Anna, who will tell us how the process and the methodology of these recommendations was, and giving us then in the end also an overview about these recommendations. Anna, the stage is yours.
Thank you, Hannah. So yeah, for the development of the recommendations, as you already said, and as also with the survey, first we created a task force or task group that consisted of healthcare professionals and also patients and survivors, patient advocates of cancer. And through the involvement, we on the one hand wanted to ensure that during the preparation and also in for the end product that we wanted to ensure that the recommendations would also really reflect the perspectives and the real life needs of the young cancer survivors. But on the other hand, of course, it is just as important to assess the perspective and the opinions of the healthcare professions to see either what guidelines are already implemented in everyday clinical practice or what can we do or what can be used to help an implementation of those guidelines. And also for the whole process, this task group was coordinated by a healthcare professional and together with a patient expert from the beginning to the end, because we wanted to follow a PPIE approach, and that stands for the patient and public involvement and engagement, which refers to the active and meaningful inclusion of patients, carers, and members of the public in the planning and dissemination of healthcare services and research. And the goal with this approach is to ensure that the needs, experiences, and perspectives of those that are directly affected by the health conditions are integrated into the decision-making processes. And first of all, in order to capture the current status of the research and practice, we did a systematic search of already existing guidelines and standards of care, specifically on the topic of psychosocial follow-up care in cancer survivorship. And after we excluded guidelines because they either did not fit the topic or they were not specific to oncology or not specific to the age group that we are looking at, 20 guidelines were included in the work. But we also did some additional searches for other topics that are relevant. And this was also achieved through many focus groups, workshops, and discussions that we had during the EU-CAYAS Net project to also include these topics in these recommendations. And then we had a consensus process. On the next slide, please, Hannah. So we had 2 consensus meetings. First of all, after we looked at all these guidelines, we tried to group them together topic-wise. So for example, every guideline that had something for the surveillance of psychology, we regrouped together. And this we did for each topic and prepared this in a lay language kind of to present to the consensus group and also with examples and figures so that everybody knows what we are talking about and they're understanding what is already out there. And then for each of this topic group, basically, or for concrete recommendations, we asked the participants, first of all, if they agree with the recommendations that are already out there. Then we asked how important the topic is for them. And also we asked if there's anything missing in these recommendations. Hannah, could you continue? Yes, one more. Thank you. So for example, for the basic psychology surveillance, our consensus group, for example, mentioned that in most of the guidelines that are out there, the carers are not listed, and also, for example, the siblings are not included. Or someone, as you can read here, mentioned, for example, that there are often many services out there, but the survivors are not aware of them. So there needs to be also this kind of communication to the survivors so they know where they can engage with the services that are actually existing and implemented. And after these 2 meetings, we came up with many topics. And during these discussions, we also saw that there are some like overarching issues or considerations that should be kind of applied overall. So we could not group them to a specific topic, but we called them then the general considerations for the care of cancer survivors and their family. And so they have been kind of consolidated from repeated input and shared insight from these consensus meetings. Can you go to the next slide, please? And these are kind of things that should be always in the mind of healthcare professionals and everybody during when delivering psychosocial care. So first of all, it was, as I already mentioned, that the care must always include also the family and caregivers, and that survivorship care should not only be designed for the patient, for the young person, but also their family and caregivers, who are also essential partners in navigating late effects or long-term psychosocial outcomes. Another one is that it should recognize and address stress and stigma, because survivors often experience long-lasting psychosocial stress or stigma. And it would be important that these factors are also acknowledged and talked about, and basically that people are made aware of this, and to keep that in mind. Of course, dedicated and competent professionals are always essentials, and survivors should also receive developmentally informed support. So professionals that are involved in long-term follow-up care should have an understanding of child and adolescent development, and also how cancer and its late effect can affect the critical developmental milestones, for example. Surveillance should also always be tailored to the needs because of the complexity and of the timing of late effects. I think it's hard to have like a strict structure that is the same for everybody. So of course, if it's possible, it's best if the surveillance is tailored. There's also an increased need for complementary psychosocial support. So psychosocial care must be more comprehensive and regular in the survivorship phase, since challenges often intensify or can emerge over time, so at a later point. And of course, ongoing research is also urgently needed, so continued research into late effects, psychosocial outcomes, and effective interventions for survivorship is essential to continuously improve also the standards of care. And now I want to give you a quick overview of what the document of the recommendations look like. So basically, I will first show you the table of content, where you can also see first an introduction into the topic, where we also explain again the methodology, and then you can find the general considerations that I just mentioned. And afterwards, you can see the specific topics that we have included. So this ranges, for example, from social aspects to neuropsychology, fatigue, but also, for example, fertility, and a lot about the communication about fertility or fertility issues. And for the last two topics, so peer support and grieving and loss in survivorship, for these two, there's not yet a universally recognized standard of care. It does not exist yet. But these topics came up so often during many discussions, many meetings, and all the time from the community, that we felt the need to somehow include it in the recommendations. So what you can find in there is content that draws from ongoing interdisciplinary discussions, also from consensus within our consensus group, but is not yet a formally established or evidence-graded clinical guideline. But we wanted to give these topics a place, so maybe that in the future there will be an evidence-based guideline through a systematic review and also broader validation across different healthcare settings. And yes, thank you. And now with as an example, so for example, each topic has its own chapter, and everywhere you can find also the original sources, so from which guideline we took this information. So you can also always go back and check the original sources. Then each topic has an introduction where we explain why we included the topic, what it actually means, and what is needed. And after this, you can always find the recommendations that we created within the consensus group with already our feedback in. And then at the end, you can again find the sources for each recommendation and a comparison of the standard that is already existing out there, from which we took the sources from, and our recommendations on what we adapted, basically, what our consensus group adapted. And for example, as you can see here for neuropsychology, sometimes it's only really minor adaptations. For example, we added the word patient, survivor to the word patient. or we, instead of children, we said children, adolescents, and young adults. And this might seem like a small change, but this is really to reflect a more inclusive age range and also to emphasize the continuity across developmental stages. And this is actually really intentional and meaningful as language also shapes the way we perceive or address or prioritize care. And this can also influence visibility or inclusivity and responsiveness. So for us, it was really important to also include seemingly small changes. And for a short example of how these recommendations might be implemented again with the example of neuropsychology. So, for example, here there's currently a position paper being drafted in the DACH region, so for Germany, Austria, and Switzerland, on the neuropsychological care during treatment, but also in survivorship. So this is actually already under review, and we hope it's published soon. And for example, also often it's the case that neuropsychological assessment is implemented during active treatment, but not during follow-up care anymore. So this can, for example, be started with research projects where it started to also include neuropsychological assessment in follow-up care or in during the transition process into adulthood to help the implementation into clinical practice. And yeah, that was basically first insight. Thank you very much. And thank you, Ian, also for sending the link. And you can also here on the QR code go directly to the document if you want to have a closer look at it and download it.
Thank you so much, Anna. As Ian kindly already put the link into the chat, I will stop sharing here. And in case you're interested, you can go back to the chat and open the link there. Because actually, we are now already arriving at our panel. First, maybe before we start with our panel, are there any burning questions for the recommendations, for the process, or anything else that we just talked about from the audience side? Okay, I would count this as a no. Don't worry, in case there are some questions, you can still arise them, but I would suggest to go forward then with our wonderful panel. So I'd like to welcome now first Andreas Peierl. Andreas is a pediatric neuro-oncologist working at the Department for Pediatric and Adolescent Medicine at the Medical University of Vienna. And his research focuses mainly on high-grade glioma patients. So welcome, Andreas, and thank you for being here today with us.
Hello to everybody.
Next on our panel is Eva Maria Tinner. She's a pediatric oncologist at the Children's Hospital in Zurich in Switzerland and specialized in the field of palliative care. So hello, Maria and Eva Maria, and thank you for being here today with us.
Thank you for the interesting panel.
And then we have Aleid van der Aa, who is a clinical psychologist working at the Later Clinic at the Princess Maxima Center in Utrecht, the Netherlands. So welcome, Aleid, and thank you for being with us here today too. It's great to have you.
Thank you, Hannah.
Then we have Johan de Munter from Belgium, who's a nurse especially focusing on AYA care. And it's really great to have you back. Johan, you have already been in other of, especially of our EU-CAYAS net events, and it's great to have you here too today. Welcome.
Thank you very much for the invitation and welcome. Yeah, let's welcome a nice, great panel here discussion.
And last but not least, Oriana from Portugal, who's our patient advocate here today. So patient advocate from the AYA field on the one hand, but also a psychologist, working as a psychologist. and also already a participant and a big, very important member from our EU-CAYAS community. And we are very happy to have you here today to present and advocate for the patients community. Oriana, welcome.
Thank you, Anna. Hi, everyone, and thank you so much for having me today.
It's great. I will just, for better visibility, sorry, put our speakers, I hope this is possible, in the spotlight. No, that's not possible. Okay. Then I will remove this. Sorry, Allied. Now you're in the focus. Oh, how can I end this? Ah, there. Okay. Well, then we need to deal with it as it is. You can see the speakers and the panelists. You can recognize us by the white background. So, let's start maybe with the healthcare professionals. I will not call out one of you, so I would like to ask you to be brave and just step out and be the first one for answering these questions. So, looking at the things that we just heard now, and also the issues that we have addressed before, is this or are these issues that we have addressed when we look now at mental health and psychosocial support for people living with and beyond cancer? Is this something that is familiar to you? So is this something that you can also see in your day-to-day work? And is there maybe something that especially kind of jumps out to you from your side in your work with people affected by cancer at a young age? Johan, go ahead.
Maybe I will start with
Yes,
answering the
perfect.
question. So I can speak from both sides because I worked as a cancer nurse consultant in hematology and for young people, and now I'm working for the last years as a cancer nurse manager. And in both positions, you see there is a big need of support and information. And I was, struck by the numbers you presented again. Because we think we're doing very well, but if you see that even 50% of the people feel that you're not informed or didn't get any information how to live beyond cancer and support a life in after cancer, in a way. And also, for example, that there is a high need, like 57, as I'm saying correctly, 57% said
Yeah.
like there's a high need or there is a need that needs to fill in. So there is, I think, still a massive area of improvement. And I think it's in both ways. I think we need to do it from the healthcare professional himself in relationship with the patient. But I'm also looking to, as a responsible, as from management side, that we also need to encourage this and try to improve this by supporting in different means or healthcare professionals so they can provide that information. And at the end, that patients feel well supported and not left alone with this information. And I think one of the important words, I think, in everything is like how we want to do this tailor-made to patients, because I think just delivering a booklet in the beginning of the treatment will not work in a way. And especially for this, because you said that it's a continuum and things are changing over the continuum, the transitions play a role and what's happening with the patient, how things going well or not well, it changes. We need to find a way to work in that continuum and to provide the right information at the right time. And I think especially the work you did in these recommendations is like the existing standards is to give this add-on that is specific to a specific group, helps healthcare professionals really go in depth and to take attention for it. But there is still a room for improvement, and I see a role for healthcare professionals, patients, but also for management in hospitals to take this up.
Yeah, indeed, Johan. Thank you very much for that very strong statement. And I think you mentioned something that is really important that also I keep to repeat all the time, that this is really a process. So this is not just one time point where you can quickly address this, but this is really something that needs to be worked on together in kind of a co-developed process by the patient or survivor together with the healthcare professional, because yeah, it's a huge thing, and that's why you cannot grasp it at just one simple time point. So this is something that needs to be continued over time again and again. Maybe Elite, for you, what's your opinion on that from the the psychosocial healthcare professional side when we yeah, address this issue of being a process and also having still this huge gap when it comes to psychosocial support for people living with and beyond cancer?
Well, um, it's difficult for me to to address this issue for all the countries in Europe, because I think the differences are really big. For instance, in our hospital, we now have two late effect clinic psychologists who are dedicated psychologists for just the survivors in our late effect clinic. But I know that there are countries who don't have this. So yeah, I think we need to work together in order to bridge the gaps between the standards of healthcare. But also, reading the recommendations, it really made me realize that we don't pay a lot of attention to the family and relatives and siblings of the people who live with or beyond cancer. So that's really something we need to address. But I'm looking for collaborating more in order to improve the healthcare. And another thing that struck me when I was reading the report is that we don't have a lot of research on what therapies do fit with the group that we work with. There's not a lot of research published, and it's very difficult to do this kind of research. But I would really advocate to do more research on interventions. So
Yeah. Thank you, Elite. Maybe as you just mentioned that you within Princess Maxima are, let's say, quite developed when it comes to long-term follow-up care, but is your observation still that this need when it comes to psychosocial care also in survivorship is indeed that high as we just described it with the outcomes also of the study?
yeah, it is that high. And what I find difficult is that, and that's why I really liked what you were saying. Let me look at my notes. That it's a spectrum, and it's not all of it is a disorder. But I think if we address the issues when it's still in a spectrum and not a disorder, we can prevent a lot of very severe problems. So yes, the need is high, and there's also an issue where people who have seen other psychologists are very often misunderstood by those psychologists, and that's not to make them to disqualify them as psychologists, but as a psychologist, you need to know a lot about a lot. So we are not very much specialized in a certain area of care, and I think this survivorship issues, they are very. You need to be specialized in order to know, what their issues are. And an example is I don't see suicidal thoughts or plans a lot, but if I ask people, would you mind not to wake up the next morning? I'm sometimes shocked by how many people say, yeah, I wouldn't mind. So it's not, that's a different way of, not wanting to live. So we need to look more carefully instead of, asking it in a very standardized way. I hope this makes sense.
Yeah, no, totally, totally. No, thank you for sharing these experiences. It's yeah, even for me sometimes unbelievably shocking to also hear this, because it clearly shows that even in countries where we are so far ahead when it comes to long-term follow-up care, like you are in the Netherlands, that still you can clearly see that some needs are still not met, maybe early enough. Let's put it like that.
Yeah, and at the same time, maybe it's also good to say, in order to, to address all the needs, we also have our limitations, and it's very often very helpful to call the psychologists that they are already involved in, and just to talk from colleague to colleague and explain a little bit about the issues that people are confronted with, because you can really educate your colleagues sometimes.
Yeah.
So, yeah.
Yeah, this is actually something that we can see definitely, that education is not only lacking in the patients and survivors themselves, but also in other healthcare professionals that are maybe not as much in contact when it comes to oncological topics. But we still need this education, because at some point you will get in contact with primary care or with healthcare professionals that are maybe not oncologists or included into the oncology field. And there we definitely also need more education, so that also the amount of resources that we have when it comes to different kind of supports gets definitely bigger, also for us. Andreas, you are coming from the pediatric neuro-oncology, coming from a quite specialized field. What are your observations? Do you also agree with the needs that we just described? Is there maybe also something more that comes that you can see within your field and in your work that we maybe just did not mention? What is your feeling and observation within that?
Yeah, what was striking for me is that in the presentation there were two-thirds of the people who answered, two-thirds of the participants answered that they were not informed about their disease and about not informed enough. And the second thing is that half of the participants said their need was misunderstood, which are striking numbers. And this might be like we just heard. We ask standardized questions, and maybe these standardized questions are not always good enough to get the needs of the people.
Yeah. Do you mean standardized tests when it comes to
Standardized tests and standardized questions. Yeah, we always ask in a medical kind of way. This
yeah.
might not be enough.
Yeah, definitely, because we have gray areas that might not be covered then by these standardized questions. Yeah, definitely. That's an important point that should be a bit more focus on. Yeah, thank you, Andreas. Eva Maria, is there from your side anything that comes to your mind that you would like to add also to that discussion?
Working with long-term survivors, I think I was aware of all these problems. But even in Switzerland, where we probably have a health system that has quite a lot of money, there are not enough resources to address all these problems. And especially the time of consultation is limited. And this is a danger if you want to implement such recommendations, because addressing or doing these screenings takes time, and you also would need to have a bit of time to talk with the survivor about the findings. And the other thing is that, especially if you also see adults, psycho-oncology is specialized for stroke victims, and they, at least in one of the centers I work at, if you send the survivors to the psycho-oncologists, they say they might be depressed, and then the psychological problem needs to be treated first before I do the testing, and they don't have an awareness of cognitive problems that might be caused by the cancer diagnosis. And it's not that easy to educate them, even if you write a letter detailing why you want to send them to them. So I think lobbying is a big part of implementation.
Yeah. And when you say it's not easy, do you mean it's not easy because it's such a complex topic, or because there is not the willingness to understand from the other sides about, okay.
Sometimes it's just that they think they know enough, but it's center specific.
Yeah.
I work in two different centers, and one of them is very open and listens to what we wrote or reads what we wrote and then looks at our patients.
Yeah.
And the other one, they just, they seem to be very set in their ways.
Yeah. It's so interesting. I once did in an event that we had, I did kind of an experiment, a social experiment, asking everybody that ever had cancer or knows somebody that had cancer or is having cancer to stand up. And out of these, I think it was 57 people, 56 stood up, meaning that everybody knows somebody or is maybe someone themselves that got in contact with cancer. So this is such a big topic and such a big issue in today's society. And still we know so little about it and are so less aware about all the things that are coming along with it. It's horrific, actually, I think. But yeah, we'll keep going and do lobby work and do advocation for that, hoping that yeah, the issue gets familiar more and more with the people out there.
Yes, and
Yeah.
especially if you want to include siblings and parents, then you really need funding because that's not covered
Yeah.
in
Yeah.
most health systems, probably.
Yeah. And we know that this is not only that cancer is not only meeting one person, it's actually something that meets whole systems, right? So actually the whole system is suffering under that disease and the treatment that comes along with it. So the support is needed by the whole system actually. So yeah. Thank you, Maria. Eva Maria, sorry. Oriana, coming now to the patient's perspective. And I mean, I know you have been included also into the development of the recommendations. Um, do you feel fully seen when it comes to these recommendations, or are you still having the feeling that some topics might be missing, that, yeah, maybe need to be included in the future also?
Yeah, I think for now the recommendations are already very comprehensive and would be fantastic that if we had this effectively implemented across all the EU countries, because as Alaya mentioned, there is a lot of disparities between EU countries. But I can see a room for improvements, of course, because as we were discussing here, this is a continuum. And I can comment so many things that have been said before, because right now I still feel like I'm learning, understanding myself in my lived experience with cancer. So, but starting by the things that I can immediately see now that maybe not really tackled in these recommendations. I think sexuality was mentioned in the fertility chapter, and I think it deserves an entire section. First of all, because I want that would be clear that is not just something related to reproduction. And also because I think we cannot deny what is going on in Europe right now with political movements. And I think we are all vulnerable in every section that are in the recommendations, but LGBTQ plus community is even more. And I think we need to address also this community in sexuality, especially transgender. So I think that is missing for now. Also, this side that we were speaking, the siblings, the parents, there is a point in these recommendations mentioning also the parents of young adults, and that is great because it's super different to be speaking of parents of children versus young adults in their specific needs. I used to say this when we are thinking about young adults, parents, they have the age of the grandparents of a child. So the needs, the risks they have for isolation, depression, the conditions they are living because the life stage where they are different. So that is mentioned in these recommendations, and I really like that. But I'm missing, for instance, the partners, the spouses, because young adults have these spouses and children who had cancer and survived. They will have survivorship when they are adults. So it's more than the original family, but also the built family. And then I was listening, and I was listening to these complex conditions that we may have that we do not know if is depression or if is caused by hormonal imbalances, for instance. Chronic fatigue. Fatigue is one of the sections that was discussed in the recommendations. And I can share that I only learn about fatigue when I start joining patient advocacy groups. Nobody told me before that I could feel fatigue. And later, I was learning what was fatigue and if it was due to my hormonal issues, if it was because I was depressed, I couldn't know. So I'm still learning all the time. And this is very, very complex. So I think there are many things that should still be included. And I'm also learning, for instance, in fatigue, that there are differences in long term that maybe now we think that is anxiety when we are going to the checkups and we feel the fear of recurrence, etc., and that can impact our fatigue. But as a long-term survivor, I'm feeling like now I have exhaustion or burnout when I think about going to appointments for my multiple conditions that I gathered because of my survivorship. So there are many things that I think we will still need to understand. And one thing I particularly like from the recommendations is that this is considering the biopsychosocial model. So the social dimension is there. And again, we are facing so many wars, political changes, climate changes. So I can give you this example that I passed recently. So Portugal was hit by what the experts call a train of storms by the end of January, and my region was very, very affected. So the devastation, the destruction in infrastructures, nature, we were several days without communications, light, everything changed. So basically for a month, I couldn't do a normal routine. I couldn't go to my gym where I had a pool. So I used to do exercise almost daily to function correctly, to help me to manage my side effects, and I couldn't. So this impacted me not only mentally, but also physically. And this is the cycle, right? Because you cannot take care of your physical condition, then you feel different mentally. So for like 2 weeks, I was very functionally, professionally, I was functional, but like 2 weeks later, I was noticing that I was waking up with tension in my jaw, and I was having some fragmented dreams about the storms. And I could relate that to PTSD because I'm informed, and then I could manage it properly. But so you can see how we are more vulnerable. And when something like this happen, we are even more vulnerable than everybody else. And it's very easy for us to collapse in a way if we are not helped to manage this, to navigate. And I feel like many survivors, and I will use these, are still navigating alone.
I so agree with you, and you actually addressed now several things that I want to kind of pick up. The first one is, again, the broader system that each patient and each survivor is living in, because indeed we just now addressed the very close family, like parents and siblings, but indeed, especially when it comes to the AYA group, we of course also have friends that might be from a certain age on, much more important actually than the family might be, as also as the partners. So this whole system needs this kind of support. Also, getting help in dealing with this huge impact that a cancer diagnosis has on the life of different kind of people. So yeah, this is something that is definitely not addressed enough and not in the mind of people enough. So definitely agree with that. The second thing is, and there a very ironic thought came to my mind was when you addressed the topic of sexuality. And I mean, we know from the interaction with the community, from EU-CAYAS and also from Jorin, that sexuality is definitely an issue that is not addressed enough. And I thought, so the ironic thought that I had was that we actually are having a taboo topic within a taboo topic because society doesn't want to talk about cancer, but they don't even talk about, like, there is much more of a hurdle on talking of sexuality of cancer patients or survivors because nobody wants to think about that, right? So actually, we're having a taboo topic within a taboo topic, and yeah, we need to address sexuality, but also the body image much more, and also keeping it apart from fertility, because fertility is one thing, but the thing that actually comes before, because we know that sex is not only something that we're having for having kids, but also should be something nice and something that everybody is able to enjoy. So yeah, definitely need to keep this apart and address it as an extra, very important topic for being able to increase the quality of life that every survivor is living, independent of the respective gender. And the third point I forgot now. It was something that you said in the end.
I also feel about myself sometimes. So.
No, but very important points there, Oriana. So thank you very much for sharing that. Maybe the third point comes back while we were going on. But before I go on now with the next question, is there an input or a question or some additional thoughts also from the audience that you want to share? Yes, Katja, go ahead. So you have shared it in the chat. You would also like to come back to the primary healthcare providers, their importance for care and their need for education. One way to set this up is a systematic way to conduct CME courses organized within the national CME systems. In Germany, the relevant organizations are Ärzte and Psychotherapeutenkammern, so the societies of doctors, but also of psychotherapists, which provide really these certified courses. However, I suppose those courses have to cover a broader patient group to be attractive enough for primary care providers. Therefore, for Germany, you see a chance to collaborate with representatives from other pediatric somatic diseases, starting in childhood and have kind of chronic character in adulthood, and then mental health after childhood cancer is one important chapter in the whole course. Yeah, definitely agree on that. Are there any experiences in other countries to provide those courses with other disciplines starting in childhood implemented within the national CME system? So I guess this is a question for our panelists, or maybe also something from the audience who knows more about that, because unfortunately I cannot answer that question. Is there anybody who has an expertise on that?
I think across Europe there are initiatives to create these networks and to let care continuing from what is in hospital delivered and what's going over to primary care. But what I also see is that a lot of countries are struggling with this, and because one of the things is like lack of knowledge, and of course, like if people going back to primary care, primary care has to deal with all the things. Next to the specific things we maybe need to deal in the hospitals or specific settings. But there are some initiatives that have like these promising things. I think like EU Net CC is where we try to, like in the cancer plan, European cancer plans, that like the comprehensive cancer centers, they need to collaborate in a way to create that network and create that network locally, but also internationally. So this could be an opportunity where we disseminate and to spread this knowledge and creating these courses and create a network of experts and also in the different levels from, for example, like primary care also to specialized care and vice versa, because it needs to be going back that people stay connected to each other. Because, yeah, if you're looking to primary care, like a GP, for example, we could support them and we could give him like CME and everything. But sometimes it's the fact that if I'm looking to some GPs I know, they're saying like, in my whole career, I never saw somebody of young people with cancer. And for example, the next GP in a couple of miles further saw 3 or 4 people. So it's also depending like who we're going to train and the investment. But I think the important is that we can create that network and that we hopefully in the future we can deliver the care that is specialized in specialized centers. And if it's not to be the specialized or generic, I would say, and this is geriatric instead, like because everybody needs these guidelines. Everybody will confronted with some of these topics, definitely somewhere at some point in their treatment or after treatment in survivorship. So I think that is also something that we need to make visible for patients and for the community where we can get this support, because that was also one of the numbers you presented, that they even don't know where to get the support. So navigating and make this visible will be also a very important thing to do, I think, in these projects. But there are some promising projects on it. So let's keep fingers crossed. And therefore, I think it's all our responsibility to take these guidelines and advocate with it, but also going to national societies, but also international societies. Like I was thinking, ESMO, CCI-E, EONS, MASK, whatever, we should all advocate for it. And maybe prevent also that some people reinventing the wheel. And I would say, like, yes, we need to invest in research, but let's invest in research that matters for patients so they are involved in it, but also that builds on the research that already exists. And I think that is also that the one thing we need to advocate, take it up and disseminate it as much as possible so that people are aware that we are definitely in need to create that network.
Thank you, Johan. And actually, you are already picking up the topic kind of for my next and probably final question, or as the time is running, because I was wondering, as we're talking now, or you also were talking about a lot of EU projects, and this is now also happening within a EU project, but also thinking about people on the national level that are maybe not in the first place included in any oncology care. Do you have the feeling that the things that we are doing now on this level of European projects are reaching the people that need more education? And in case they're not, is now these recommendations, is this a tool that you can use for advocating for these needs that we are provenly have out there? Or yeah, maybe that's my question. I hope you got my question.
I can start to answer, but looking to the
Yeah.
panel to jump in if they want. But I think definitely you have created something that we can use to advocate and to move things further and to maybe change the national standards and what is already out there. Eventually, it will be not just one moment that we need to think about it. It's something that also we need to continue to do this. And every time these discussions come up, we need to come with this guideline and saying like, no, this is how we should do it. This is how we should present it. This is how we should implement it. It's already written. We don't have to redesign this or whatever. So it's all our responsibility to do this. Of course, does it reach at this moment? I would say the nurse, the physician, the physiotherapist, the psychologist are in local centers. Maybe not at this point, but that's why I think that the comprehensive cancer centers, the EU NetCC, where they are hoping to create that network across Europe, but also nationally creating these networks, that we can take there up the responsibility to disseminate this until we are at the final layer to disseminate and that everybody is aware about the standards. And therefore, I look also to, for example, like the big organizations that write the guidelines to take it up, like, for example, ESMO was had creating a guideline on adolescents and young adults. They'd have to take this up, refer to this work you did, this great work you did. But of course, there's a lot of opportunity also because you said also, like, for example, peer support and grieving and loss in survivorship, there's still not kind of standards, but maybe that's also not always needed because this is also related to, for example, cultural things also that people can create this on their needs, their specific needs they have. And therefore, I'm looking also to the network that we can share it with each other and keep continuing sharing these important guidelines, thoughts, creation, this work to do it. So it's not one time specific moment, but it's our responsibility to keep it alive and to push it forward until everybody is informed.
Yeah, very much agree, Johan. Thank you very much. Eva Maria, as you are the next one on my screen to Johan, what are your thoughts on that?
I think it's something that each representative of a country needs to do locally. In Switzerland, we did have a guideline group that developed not a scientific guideline, but a consensus guideline that also included psychosocial topics. But I think some of the asks of this guideline are probably quite difficult to implement, like the screening every year, for example. In adult medicine, I don't see that being realized soon. And I wonder if sometimes it would be important just to have a safe haven where people can contact if they experience upheavals in their personal lives. Because what I heard from Oriana, this vulnerability is something that the survivors I know experience as well. For example, if you're in a divorce process or if you have a new health problem that is diagnosed, then they need somebody they can contact, and that helps them find the professionals that support them in this situation.
Yeah.
So, yeah.
Yeah. Thank you, Eva Maria. Next to you would be Andreas. Are you having some additional and final thoughts also on this? So if these things that we are developing on in European projects are already reaching the national level where it needs to be addressed, or are the tools at least that we are developing something that you can use or that can be used in general for advocating for all these needs that are still out there?
Well, I think it was very, very important to have this webinar talk and to get all these needs and these recommendations. And many of them are implemented, but not all of them. And I think and we will work on to implement all to get the needs and the involvement of all patients in the future.
That's very good. And I know that I can rely on your team. That's is really working hard on all of these topics. So thank you very much. Elise, some final thoughts also from your sides.
Yes, um, I think it's still difficult to reach everybody with the guidelines. Otherwise, there would be thousands of people now joining this webinar, I would say. But that's also the situation in our country, and we are really struggling with, how to find a new group of survivors, not the people who we see every time at the same meetings. Yeah, we are discussing how to do that. And yeah, I think the documents that you developed are really useful to, to advocate for, yeah, improve healthcare. And at the same time, I would say, that we also have to discuss if certain issues need to be part of the healthcare system, or also need to be addressed in the educational system, or in the, system of employees, or, in the working world, if you get what I mean, because we cannot pay everything with healthcare and insurance money, and that's also, yeah, something I would really like to discuss within the European setting. How we can do that.
Yeah, very much agree. Thank you also for that, Elise. Eva Maria, you have your hand raised.
I just wanted to add and highlight what Hanneli said in the comments, that I think the networking with PanCare would be a great resource, because there are also a lot of research projects that come together there and a lot of expertise.
Yes.
Yes, thank you very much also, Hanne, for putting this into the chat. I think in general, networking is the keyword in here, because we have developed an amazing community when it comes to all of these topics in the last recent years. And I think that this is the key for all the things to come. So I could not agree more. And thank you also for sharing this in the chat, Hanne. Yeah, so everybody being interested, just have a visit at the chat and see the link that Hanne put there.
Yes, and not only researchers, but also healthcare providers. It's, the collaboration that makes it work. Yeah.
Yeah, definitely. Definitely. So we would have some last slides for you, but I don't want to dismiss Oriana with the patient's perspective. So is there anything you want to add from the patient side when it comes to advocacy? Do you have the feeling that these recommendations that we have developed are advocacy tool that you actually can use? Yeah, so what are your thoughts on that?
Of course, I think the recommendations can be like the foundation for you to go to your own countries and join other patient advocates or organizations and try to fight for the rights. And also, I think, once again, it's important to bring the patients to the table. I mean, even involving them politically, because the things that are discussed are for us. And I think this is the difference from what we were discussing here, sometimes what is in the recommendations, it's not clearly understandable for the professionals as well. We need to materialize what that means for the patient and how can be actually implemented. So I think all the recommendations and even the materials we created at EU-CAYAS.net, I think they are great tools that we can and should use in our communities now for making, I hope, to make the difference, because we still miss a lot of data. And at least here we are collecting a lot, and that should be the part of the discussion.
Yeah, definitely agree. Thank you so much for that important statement, Oriana. So, dear panelists, thank you so much. It was a great discussion, but unfortunately, we have reached the end of our webinar. But before we leave, I would pull up one last Slido because actually we would be very much interested in let's hope that this works in the end, because we would be very much interested also now from our audience. What are the things that you are taking now home from our presentation and from the discussion that we had afterwards today? So what will stick with you? What, yeah, maybe motivated you also to start or restart your advocacy work? That would be interesting. So we have collaborate or the power of collaboration for moving forward. That's great and very powerful. It feels very powerful actually. So very good to read. We have medical questions are not enough to answer all the needs. We need more. Definitely agree. And I think this is also something that we wanted to have in there. So that's great that we could bring this over kind of. The need for involvement, very good. Yes, indeed, also a very important message from today. We have lobbying and collaboration, definitely something also that comes kind of hand in hand when it goes after what we're imagining. We have educate healthcare professionals. Yes, indeed. We have setting the standard is done. Now the work starts and continues. Yes, very much agree. Implementation takes a long time. Yes, unfortunately, but I hope we will not get tired to put this work forward. Then we have the need for networking and collaboration. Very good, an important message, and I'm glad we could that this is going to stick with you. Then the need to close the intention and action gaps. Yes. We have include taboo topics. Yes, indeed. I very much agree on that. So that's great. I can see that nobody is typing anymore, but this is really, really a great list. And I'm very happy that these are actually the take-home messages for you, because this is what we wanted to achieve with this event today. So thank you very much for your active engagement. And before all of you are leaving, I also want to make you aware about our next webinar that is happening at the end of May, to be exact at May 27, same time as today, so at 5 o'clock after Central European time. And this will be about living a healthy lifestyle after cancer. And we are going to listen to young voices, but also understanding the expert perspectives. And we will try to explore the challenges and opportunities that young people that are living with and beyond cancer, trying to live healthy lifestyles in that phase. So you have the QR code aside for registering directly, so you can also join us for the next time. And I very much hope that we are going to see each other there. And with that, I can only say thank you very much in participating today, in taking the time and joining us in this wonderful webinar. I'm glad to see that you could take so many important things with you. And yeah, as already said, I hope we're going to see each other at the end of May in the next webinar of our quality of life webinar series within the Yarn project. Thank you everybody so much. Thank you also for the great panelists for taking the time and participating today. And with that, I say good night and see you next time. Bye bye.